My name is Cynthia Trudgeon. I'm a respiratory therapy student at Great Falls College, and today I'll be presenting two emerging technologies, diaphragm neurostimulation and AI-assisted weaning, and how these are changing how we approach ventilator liberation in critical care. As respiratory therapists, you know how challenging weaning can be, especially in patients with prolonged mechanical ventilation. These new tools aren't meant to replace RT judgment, but enhance it. My goal today is to show how these innovations strengthen the diaphragm, support clinical decisions, and ultimately reduce time spent on the ventilator. By the end of this presentation, you'll understand the mechanism of diaphragm neurostimulation, how machine learning-based tools analyze respiratory patterns, what recent research like the Rescue 3 trial shows about patient outcomes, and how these technologies fit into the daily workflow of an RT. We'll also touch on barriers to implementation and what future practice may look like. As a disclosure, I have no financial relationships or affiliations with any companies discussed in this presentation. All of my sources are academic and peer-reviewed. Now let's first talk about why reducing ventilator time matters. One of the biggest problems with prolonged mechanical ventilation is diaphragm disuse atrophy. In as little as 18 to 24 hours of inactivity, the diaphragm begins to weaken measurably. This weakness directly impacts weaning success. Another major factor is the increased risk of ventilator-associated pneumonia, higher mortality, and longer ICU stays, all of which increase cost and resource use. About 20 to 30% of ICU patients become difficult to wean, meaning they require multiple failed attempts. These are the patients who benefit most from early intervention and more precise physiological monitoring. Because of this, we're seeing a shift towards technologies that preserve diaphragm function from day one rather than waiting until the weaning window. Diaphragm neurostimulation works by activating the phrenic nerves, causing the diaphragm to contract in a way similar to natural breathing. Unlike pacing devices used in chronic ventilator-dependent patients, this is temporary and transvenous, and it's usually inserted through the femoral or subclavian route. This stimulation is synchronized with the ventilator cycle, meaning the diaphragm contracts during inspiration instead of staying passive. This prevents disuse atrophy and helps restore strength over time. Clinically, this matters because even if the lungs are ready to wean, patients often fail due to muscular fatigue. By actively conditioning the diaphragm during mechanical ventilation, we improve endurance and increase the likelihood of successful weaning. Now we'll talk about this in a real-life scenario, the Rescue 3 trial, which was published in the AJR-CCM in 2025 and is one of the most promising studies that we have so far. It included 216 critically ill adults randomized to receive either the AeroPace neurostimulation system, which you can see in the bottom right-hand corner, or standard care. The treatment group showed about a 50% increase in the diaphragm strength measured via twitch pressures. That's a massive improvement. This level of strengthening typically takes weeks with traditional therapy. Most importantly, the neurostimulation group had 3 fewer days on the ventilator. In weaning research, a reduction of even 1 day is considered meaningful. 3 days is a huge clinical and cost-saving impact. There were no significant device-related complications reported, and weaning success, defined as remaining off the ventilator for at least 48 to 72 hours, was significantly higher than the treatment group. This trial is a large step toward integrating targeted diaphragm rehab into routine ICU care. Machine learning models evaluate data that RTs normally interpret manually, such as flow waveforms, pressure curves, respiratory effort, breathing patterns, and even subtle changes in variability. Algorithms such as random forests, logistic regression models, and convolutional neural networks detect patterns indicating whether a patient is ready for a spontaneous breathing trial or whether they're likely to fatigue. These systems don't make decisions for us, but they give real-time risk assessments, allowing RTs to intervene earlier. One exciting area is prediction of failed SBTs before the patient actually fails, something humans often can't detect visually. Long-term, these tools could support not only ICU weaning, but even home ventilator management for chronically ventilated patients. Rehabilitation has always been important during ventilator liberation, but pairing it with AI allows therapists to tailor intensity and timing based on physiological responses rather than a fixed protocol. AI can detect when a patient is becoming fatigued during mobilization or breathing exercises and make recommendations. This avoids overtraining but ensures adequate conditioning. RTs are key here because we integrate mobility plans with ventilation strategies, ensuring that diaphragm protective ventilation and mobility don't compete with each other. When thinking about implementation, we also have to consider staffing and workflow. For example, who monitors the neurostimulation? RTs, ICU nurses? Does it require new competency checkoffs? AI tools also need integration with ventilators or EMR systems. If the system flags a concern about weaning readiness, where does that alert go? Does it appear on the ventilator? Does it notify the RT? Does the provider have final override? There are also important cultural factors. Some clinicians worry AI will replace clinical judgment, so part of the implementation is education, helping the team understand that AI is a tool and not a decision maker. There are still barriers before these technologies become widespread. Neurostimulation devices are expensive and require staff training, especially for line placement and stimulation monitoring. Patient selection is crucial as well. Not every ventilated patient is an ideal candidate. Workflow integration can also be challenging in busy ICUs. And finally, to reiterate the ethical questions that arise around AI, such as data privacy, algorithm bias, and how much clinicians trust and how much trust they should place into automated recommendations. RTs will play a major role in ensuring the technology is used safely and ethically. Again, these innovations do not replace the respiratory therapist. They actually expand our role. RTs guide the weaning process, and now we have tools to give deeper insight into patient readiness and muscle function. Using these technologies appropriately can reduce ventilator days, improve patient outcomes, and create a safer, more efficient ICU environment. The future of respiratory care is tech-empowered, and RTs will be the center of that transformation. As these technologies evolve, we may eventually see fully integrated systems that monitor diaphragm function, predict failure, suggest ventilator adjustments, and guide mobilization all in real time. We may also see portable neurostimulation systems used in step-down units or long-term acute care hospitals. There's also research looking at pairing neurostimulation with high-flow therapy for post-extubation support, potentially reducing reintubation rates. And AI could soon personalize weaning protocols instead of using a one-size-fits-all approach. A patient with COPD may need a totally different trajectory than a trauma patient, and AI may help tailor those plans based on physiological trends. So in the future direction, it's not just shorter ventilation times, it's smarter, safer, individualized weaning. And then again, to reiterate, these tools do not replace RTs. They evaluate our practice with neurostimulation. RTs can become leaders in diaphragm monitoring, strength assessment, and titration. AI assists with decision making, but we still use our clinical judgment to interpret the context. With better assessments, RTs can reduce ventilator days and improve patient safety. These are my main sources in guiding the evidence presented today. Thank you, and I am happy to answer any questions.